This is my third time coming to your wonderful conference, and it's always a treat. We love how forward-thinking this country is, and how much recognition there has been for the stakes and the consequences of cybersecurity, and giving me a chance to maybe add to that list that it's also cyber safety, where bits and bytes meet flesh and blood. So we're going to have other actors join, but let me get started. And notice our Twitter handles. While the revolution will not be televised, it will be tweeted, and we like to have engagement online. So again, I'm Joshua Corman. I'm the founder of IamTheCavalry.org. We just turned 6 years old at DEF CON this year, and you were gracious enough to invite me within our first year of launch in this very room. The name is a bit confusing to people, but basically what I told hackers is that the cavalry isn't coming. Those horses and soldiers at the end of the movie that saved the day, that's not going to happen. No one's going to save us. And if you know that no one's going to save us, it falls to you to maybe do something about that. So I Am the Cavalry is not Josh. It's not even the 500 or 600 folks that we now link arms with. It's you. It's a personal declaration. The problem statement I put out there was that our dependence on connected technology was growing faster than our ability to secure it, especially in areas affecting public safety, human life, and national security. Essentially, wherever bits and bytes meet flesh and blood. So we had our best and brightest focused on replacing credit cards or data breaches, which are important. I love my privacy. I'd like to be alive to enjoy it. But as we were failing to defend the Fortune 100, everyone has had a breach of intellectual property or trade secrets. Everyone has lost a credit card or had an account takeover. Our failure rate is nearly 100%. It doesn't mean we're not getting better. It's just that we're getting worse faster. And it was more about that dependence on high stakes, high consequence failures like our cars, our medical devices, our public infrastructure. Now, one of those areas, one of the ones I'm most passionate about is healthcare, because of all the things that can kill you. The one that has the lowest barrier to entry, nothing new to learn, is healthcare. If you want to hack a car, you have to learn CAN bus. If you want to hack critical infrastructure, like we heard from Rob Lee, you have to learn SCADA and ICS protocols. If you want to hack a medical device, it's Windows XP or older. So it's very familiar. And these kingdoms are very poorly guarded as well. So one of the things we did early on is we published a Hippocratic oath for connected medical devices. We said, you must be this tall to ride the Internet of Medical Things. And instead of using merely cybersecurity language, we tried to translate this into the language of healthcare providers. We don't have to tell them to care about patient safety. They already innately care about it. In fact, this is one of the oldest professional creeds going back thousands of years. So what we were doing is not giving them something new to care about. It was mapping what they already care about to our world. They scrub in before surgeries. They understand hygiene is important in the operating room. Well, so too is hygiene in the equipment. As we increasingly depend upon technology in the delivery of patient care, we have to port those practices over to that tech as well. And it was essentially how do you avoid failure, take help avoiding failure, capture, study, and learn from failure, have a prompt and agile response to failure, and contain and isolate failure. And that little closed loop system around all systems fail became the framework within which we would talk about the value of coordinated vulnerability disclosure. I don't have to tell this group how important that is, but we wanted to take those practices into the medical world. Now, the reason I was here last time is I gave you a preview by about 1 week of our congressional task force. Several of us, about 21 of us, spent a year and a half trying to study the highest risk areas to the healthcare industry. And while a US-based report, it's a global supply chain of technology, and many of our issues are global in nature. So I gave you a little preview, and without going through all of those things right now, we were talking about the top 5 uncomfortable truths. And rapid fire version of it right now, just to remind us, is number 1, there's a severe talent shortage for cybersecurity. In the US stats, 85% of our hospitals don't have a single security person on staff, not even one. There's no one that's overworked. There's no one to tell that there's something to patch. So 85% lack a single person. Number 2, they're usually defending really old legacy systems like Windows XP or older. Not only is Windows XP end of life, not only is its successor Vista end of life, Windows 7 goes end of life in January. And this is often a best case scenario. Number three, these things are prematurely and over-connected. In the race to embrace electronic health records to get away from paper copies, which is absolutely a good idea, we did it before really factoring how to do it well. And as such, these connectivity issues were very brittle, and it led to flat, wide-open networks, where it's hard to do any segmentation, and most of the time these devices are connected to the outside world and discoverable from the naked internet. And then fourth, these vulnerabilities can affect patient care. We're so focused on patient privacy, whether it's HIPAA in the States, where it's about your medical records, we realized there was more incentive to have a corpse with their privacy intact than to preserve patient safety and patient care. And as we started to see with early indications of ransomware, these attacks on hospitals can affect patient care delivery, which can affect loss of life. And then lastly, if you think these would be rare, we looked at a typical medical technology and there were 1,440 something vulnerabilities, unique CVEs in that one device. Now that might be an outlier, but it's not uncommon to have 1,000 known vulnerabilities. Now will all 1,000 be exploitable? No, just takes one. And in the first week of our task force, we saw a single flaw in a single Java library called JBoss take out a single device and lock out patient care for a whole hospital in Southern California, in LA. Now they had to cancel surgeries, divert ambulances to other facilities in LA traffic. And if it's just one facility, maybe the local area could absorb that. But what happens if it were to hit every hospital in the same area? Now, just to really center you, because it was actually messing with my head a bit when I got here, the other thing that happened is, as I was preparing to give you this preview, 3 days prior to me standing on this stage, WannaCry was our worst nightmare manifest. It happened on Friday of Mother's Day weekend, and essentially a very large ransom worm took out a whole bunch of systems, primarily in the UK government. It was a global worm, but it was very isolated to the UK. And while it was not targeting healthcare, it had a profound impact. The day I was on stage, we didn't really know how bad. We thought it was pretty limited. It turns out about 40% of the national capacity for the entirety of the UK government was shut down or degraded. In the city of London specifically, there were 0 stroke centers and trauma centers open. And if you know things about a stroke, there's a 3 to 4 hour magic period, magic hours, where you may be able to preserve brain and life. You have a very tight window. There were 0 open in London. So for anyone that tells you nobody died, or it had no effect, or luckily nobody died, the probability is not working in our favor. And how do we know this? Well, we know from a seminal piece of work in the New England Journal of Medicine that if you have a heart attack during a Boston Marathon or some other US marathon, you have a statistically significant chance of dying later. What they did is they looked at, if you had a heart attack, the extra 4.4 minutes in your ambulance ride to go around the runners had a statistically significant impact on a 30-day mortality rate measured later on. Now, what the heck does this have to do with hacking? Well, what it has to do is certain treatments, like brain, heart, lungs, degraded or delayed patient care can have an effect on mortality. So, can a mass denial of service and denial of patient care have a degraded, delayed impact? Yes. Can that lead to adverse outcomes? Yes. So, the other thing I was teasing when I was on stage is I was going to be going to Phoenix, Arizona to work with 2 hackers that happened to also have gone to med school. And we said, let's stop talking about waiting for the first loss of life, and let's give an experiential, real life, hands-on experience at what it would look like if you had real hacking intersect with real human physiology. Would the doctors know what to do? And pretty soon you're about to find out. The CyberMed Summit happened just shortly after I left your fine conference. Now, it was a very diverse set of stakeholders. We had people from the US Food and Drug Administration, from the Department of Homeland Security, from the governor's office, from the city, from administration in that hospital we were in and the other surrounding hospitals. We had law enforcement, we had National Guard, we had patients represented, medical device makers. We really saw this as a whole of community type approach, but at the center of it all had to be patients. And I said, look, people keep telling you that no one's gonna change anything until somebody dies. So what do? Like any good hacker, we decided to kill somebody. In fact, we killed 3 people initially in ER simulations. That's what I did in my summer. And using very important surgical dummies these guys will explain, we wanted to show that there can be really high consequences in a very visceral environment. For those of you who want to tell your friends after, we did a short, I think 9-minute ABC Nightline piece on the issue. It was very tastefully done. It was appropriately shocking, but also grounded in science. Luckily for you, you don't have to watch it on TV. You're gonna see something happen here on stage shortly. But because this isn't just about a single ER doc or emergency room doctor, we also did on day 2 a series of tabletop exercises where we simulated what would happen if this hospital was shut down and you couldn't deliver patient care with very simple attacks using default passwords. And in round 2, we said, what would happen if we did the same attack to the other hospitals in the city? Because they're all using the same types of equipment. It's a very repeatable offense. And then we said, what would happen if we added a physical attack, where you had an increased demand for patient care with a decreased capacity for patient care? We expected there would be a national crisis at some point in round 2 or 3. But what's stunning, and I can't get into the details right now, is we had a mass casualty event triggered in round 1. Basic assumptions that administrators and policymakers had about how resilient we would be to even small interruptions were tested and found wanting. So those uncomfortable truths command uncomfortable responses. And what we're trying to do is, instead of waiting for proof of harm, and I'm going to give a personal anecdote after the simulation that also happened within a week of my last visit here, is we really want to catalyze that moment of panic or dread. We teach our children how to escape from their school in the case of a fire before waiting for an actual fire. And we wanted to use simulations like this to do something similar. So at this point, I'm going to hand off to those 2 beautiful minds and hackers who then went to medical school. And it was through the intersection of hacking knowledge and medical knowledge that these ideas came to fruition. So with that, I'm going to hand this to Doctors Jeff Tully and Christian Dimmock.
Thank you so much. Thank you for that introduction.
We are so thrilled and appreciative to be here today with you. My name is Jeff Tully.
My name is Christian Dimmock.
And as Josh mentioned, we are now doctors. I specialize in pediatrics and anesthesiology.
I'm emergency medicine and clinical informatics.
We learned in medical school that the most important interactions happen at the bedside, and the most important relationships are between the clinician and the patient. And while we are doctors now, we were hackers before this. And with our clinical knowledge, we also understood that the bedside of today looks very different. And we rely on incredibly complex and powerful technology to help provide the amazing advances in cares and outcomes that we can. So the question is, knowing that the technology that we rely on needs to be safe and secure, how are we able to educate our fellow clinicians who don't have the same background that we do?
And that's where simulation comes in. Aviation figured this out decades ago. They didn't want to train pilots on actual airplanes. You shouldn't be training to take off or land a plane in an actual plane. Instead, they created high fidelity simulation. So they would create a mock cockpit. High fidelity, so it's exactly like it is in a real airplane. Practice taking off, landing, the basics. And then when things get more and more advanced in your training, you're able to practice in a safe environment, rare circumstances, high stake circumstances. What if an engine goes out? What if there's severe weather? You can practice this in a simulation so that when it happens in real life, you're prepared to respond. Medicine took the page out of aviation, and we do our own clinical simulations. We don't want our young doctors treating heart attacks for the first time on real people, on our parents, our mothers, our sisters, ourselves. Instead, we can put them in a fake hospital, a fake emergency department, a fake operating room, and run through the exact same medical conditions and test them, tweak them, make sure that they're doing the right things at the right time, giving the right doses of medication. To provide that simulation, we have some pretty sophisticated technology, some of which you'll see on the stage today. We have mannequins that can blink, breathe. You can do medical procedures on. They can respond and talk to you. What you're about to see is based on real research, real security vulnerabilities that were disclosed. They feature accurate medicine, accurate human physiology. What you're going to see is as close as we can get to what would happen in an actual hospital.
We have the fortune and privilege to have an amazing Dutch physician who's going to come join us and participate in this exercise. They have not been told the scenario, so they're very brave for agreeing to essentially step into a complete unknown. The other individuals that you see on stage are aware of what's going on and they will be able to help us, but this brave doctor on her own is facing a complete unknown.
There will be some points during the simulation where the patient will not be doing so well. Otherwise, why are you here? Some people may find this upsetting. We'd like to give you some advance warning. It's absolutely okay if you don't want to be present here in the room. No one's going to think any less of it. There will be live medical procedures on a mannequin. There will not be any real blood or anything like that, but we'd just like to give you a heads up that this will be intense for some people.
All right, so with no further ado, it is my pleasure to introduce our brave doctor, Dr. Lisa Tetero, a local Dutch physician who will be working with us today. Let's give her a round of So Dr. Tetero, it's great to see you. My name is Jeff. I'm a nurse here at the local A&E. It's been a pretty slow day so far, but it's good to see you. How are you doing?
I'm fine. I'm
Good.
ready to go to work.
We have no patients right now that currently need your services, but I think I did hear about an ambulance bringing in a patient for us to see, okay? So I'm going to go check in the receiving bay and see if I can bring them in.
We'll see.
All right, watch the stage here. Get moving. Already have an injury. Watch the stage. Okay. All right, Dr. Tetero, here's our patient. We'll get him into the bay. Sorry, sir, we're just going to get you set up here in our bay. Better grab me here. Lift your head up just a little bit.
Thanks, guys.
All right, Michael, do you have a report for us?
Got a 37-year-old male. He's tachycardic and has a temp of 37.2, tracing a rate of 165 BP, 114 over 76. We gave him some aspirin and nitro.
Okay.
And we made a 12-lead AKG.
Yeah, you brought it with you.
I'll grab that, yeah, we'll get that.
Right. What did you see on it?
Not much.
A tachycardia. Right.
Yeah.
So tachycardia of 160 with an adequate blood pressure.
Yeah.
Fine. Hi, good to meet you.
Hi, Chris.
That's one of the physicians. What's going on?
Well, this chest pain it recurs. It started 3 days ago during training, and just bam, hit me. And was gone, returned, and well, it's probably nothing, but well, just worried. And I called, and they really picked me up and brought me here, so
Okay.
pretty happy to be here.
Thanks, guys, we got them.
During 3 days, off and on chest pains.
Yes, yes,
And where are those chest pains located?
that's right here.
Right on the lower left. And did you have this before?
3 years ago, also during training, and well, didn't think much of it, but just when it recurs, well, really freaked me out. Yeah.
Yeah. Okay. Could you hook him up to the monitor?
Sure, I'll get him on some
And
monitors,
an
absolutely.
other 12-lead EKG?
Yeah, I think with that EKG here, I'll get that after I get him on monitors, okay?
Thank you.
Sir, I'm just going to put a couple of sensors on you, okay?
Oh, yeah.
First
I'm
one
going
is
to feel your
sensor.
pulse for a little bit. Well, good positions. So the chest pain is over here. Does it go anywhere, like the arm or the jaw? Or...
It's like to my left arm, and it comes up when I move.
It's just to cuff your blood pressure.
Sometimes it's just random. Sometimes I get dizzy, lightheaded.
Any nauseousness?
I almost fainted, yes.
And transpiration?
Yeah.
Sweatiness?
Yeah.
And if you have an episode, how long does it last?
A couple of seconds, 10, 20 seconds.
Some cold stickers here I'm going to put on
And
your
those
chest.
palpitations, they feel quick or is it just a pressure? Or
No, it's more like cramps, Yeah.
a cramp? Any palpitations going with that?
Palpitations.
Like your heart, you feel your heart racing?
Yeah.
Okay, doctor, we're on monitors.
Great. And where is the monitor hooked up?
And here's our EKG.
Thank you. I see.
I'm sorry that our monitor's sound doesn't seem to be working, but I'll try and fix that here in a moment. There we go.
What I see is that your heart rate is going really fast and irregular. I don't know if you feel that as well. It's not something to really worry about, but it is an explanation for how you feel so terrible. So what I want to do is going to give you some treatments to slower your heart rate. I'm going to discuss that with the cardiologist to see what do you want to get to do that. And if your heart rate lowers, it will get better. We cannot change something about the rhythm because of safety issues, but we can lower the rate, and that will make you feel better. Yeah?
Cool.
You know, I think our cardiologist, he's out for the moment. We've been starting people on the medications here. Is there a medication in particular you'd like to consider?
Like a beta blocker, something
Sorry?
like metoprolol.
Okay. Would you like me to start an IV on him to get him some fluids and to be able to give him that?
Get him some fluids and then give me 2 milligrams of metoprolol in a syringe, and then we'll give that to him. So it's nothing to worry about. And can we give him some oxygen? Because I see his saturations is lowering.
The oxygen's over there. I'm going to start an IV on him real quick. So this is just a tight rubber band here.
Here is the oxygen.
Needles.
Just a little tiny poke. Okay. Nothing too bad. Okay.
We have some nasal
Yeah. Takes on the back there, so we can just put. Just gonna clean things off here. Right,
And can you
little
draw,
pinch and burn here. 3, 2, 1. Ouch, ouch, ouch.
Can you draw some cardiac enzymes in the internal lab and include some TSH and T4?
Sure. So let's get this oxygen.
Any cardiac, ever seen a cardiologist in the past?
No.
No. Any other doctors you're seeing or medications you're taking?
No.
Any allergies that I should know of?
No.
And you're not like ill at the moment, having a fever or
Not at the moment.
not at the moment, not coughing, nothing. I'm gonna give you a bit of oxygen.
And I just got a message from the pharmacy. We don't have the metoprolol in stock. We've actually been using diltiazem, which, as you know, is a blood pressure medicine.
Yeah.
Similar to that. Would that be okay for a bolus too?
If you get the right dosage, it will be fine. You give an initial bolus and then
Sure.
put him on a pump.
So I'm gonna give a bolus, and then we'll get him started on an infusion like you asked.
Okay.
And I'll clean some of this stuff up here.
And are those the latest blood pressures? The upper
I think it's cycling right now.
Okay. I guess you're a bit nervous because your blood pressure is a bit high.
Slightly lightheaded.
Slightly lightheaded, yeah. Okay. At what timer is the blood pressure?
Looks like it's cycling right there.
Can you put it at 5 minutes?
Sure. So the infusion's going. Here's some of the initial lab studies for you.
Can you take this one?
Yeah. Infusion's running.
Okay, this looks good. A bit of stress, white blood cells. Good kidney function. Okay. The diltiazem is going
Yep,
in.
it's running right now.
Normal pH, normal good.
I think it's doing a good job with the rate control.
And at what dosage is it? Is it running in slowly? No cardiac enzymes. No be
You okay, sir?
Still with us, sir.
Get some of that medicine. We're doing fine.
And slightly
A little dizzy.
Okay.
Take some nice deep breaths.
Can we do the blood pressure again?
Cycle the blood pressure.
Okay. The blood work seems to be normal.
Sir, are you doing okay? Feeling okay?
Still
Sir?
Sir,
Can we get some help in here, please?
can you call the coach?
Yep. Can we get some help?
Because I'm losing blood pressure. Can you start CPR?
All right, we're going to take a break for a second. Suspend your disbelief. As we prepare the rest of our simulation, I'd like to recap what's going on. We have a gentleman who's come in with 3 days of chest pain. He's walking, he's talking, he's doing okay, but he needs some medicines to help slow his heart down. For unknown reasons, this patient has now become unresponsive. So allow us in the next few minutes to prepare the set, and then we're going to bring the lights back up as if nothing had happened. The reason